Hello, and thank you for taking the time to attend my Doctor of Nursing Practice Project oral presentation. My name is Erika Coulson, and today I will be presenting my quality improvement project titled Optimizing Glycemic Control in Type 2 Diabetes Through Structured Education in Primary Care. This project was completed at a primary care clinic within Culinary Health Center and focused on improving diabetes outcome by implementing a standardized diabetes educational toolkit. Today I will discuss the practice problem, evidence supporting the interventions, project implementation, statistical analysis, results, implications for nursing practice, and recommendations for future practice. Before I begin, I would like to thank my committee members for their guidance, mentorship, and support throughout this project. I especially want to thank my committee chair, Dr. Person, my second reader, Dr. Snell, and my community member, Dr. Mercer, for their invaluable feedback throughout this journey. I am grateful for the opportunity to work with such an outstanding committee. Their expertise and support have been instrumental in helping me successfully complete this project and grow as a DNP-prepared nurse practitioner. Type 2 diabetes continues to be one of the most significant chronic diseases affecting adults in the United States. According to the American Diabetes Association, millions of Americans live with diabetes and many experience preventable complications related to poor glycemic control. Of those millions of individuals who live with diabetes have poor glycemic control and therefore increasing the risk of serious complications including but not limited to cardiovascular disease, kidney disease, neuropathy, retinopathy, and lower extremity amputations. All of this contribute to increased healthcare utilization and reduced quality of life. Although diabetes self-management education is recommended by national organizations, education within many primary care settings remains inconsistent. Educational content often varies according to the provider, available appointment time, and clinic workflow. Within my organization, although providers consistently treated diabetes, there was no standardized educational process. Each provider educated patients differently depending on time constraints, experience, and personal practice style. This inconsistency represented a practice gap and provided the foundation for this quality improvement project as patients were not receiving the same evidence-based education during their visit. Because diabetes self-management education has consistently been shown to improve patient outcomes, I developed and implemented a standardized diabetes educational toolkit designed to provide every eligible patient with comprehensive education during their routine primary care visits. Therefore, the purpose of this project was to evaluate whether implementing a structured diabetes educational toolkit would improve glycemic control among adults with type 2 diabetes receiving care in a primary care clinic. The American Diabetes Association recommends structured diabetes self-management education throughout the continuum of care to improve patient outcomes. The ADCES-7 Self-Care Behaviors Framework emphasizes healthy eating, medication adherence, physical activity, glucose monitoring, healthy coping, reducing risks, and problem solving. Recent research also showed that structured education improves patient engagement with their medication adherence, their self-management of behaviors, and significantly lowered the hemoglobin A1C. Collectively, the literature supports that standardized educational interventions, such as an effective strategy for improving glycemic control in a primary care setting, will definitely improve hemoglobin A1Cs. This project was guided by the Iowa model of evidence-based practice. The model begins by identifying a problem in a practice, in this case inconsistent diabetes education. Next, evidence supporting standardized education was reviewed. The intervention was then implemented after organizational support was obtained. Outcomes were then evaluated to determine effectiveness. Finally, recommendations were developed to promote sustainability by integrating the toolkit into a routine clinical practice that was standardized for patients with type 2 diabetes. The Iowa model provided a systemic framework for translating evidence into practice while supporting long-term quality improvement as it guided implementation, evaluation, and sustainability planning throughout this quality improvement project. This project utilized a quality improvement design conducted with pre-intervention and post-intervention evaluation within a primary care clinic. The intervention consisted of implementing a standardized diabetes educational toolkit during routine patient visits for adults diagnosed with type 2 diabetes. Data were collected retrospectively through electronic health record review. Patient information was entered into a standardized data collection tool, ensuring consistency and confidentiality throughout the project. Eligible participants received standardized diabetes education focused on medication adherence, nutrition, physical activity, blood glucose monitoring, and lifestyle modifications. Hemoglobin A1C values obtained before and after implementation served as the primary outcome measure. The educational toolkit standardized diabetes education across all providers. The educational toolkit was developed using current ADA standards of care and the ADCES-7 self-care behaviors. Topics included medication adherence, healthy eating, physical activity, blood glucose monitoring, complication prevention, healthy coping strategies, and lifestyle modifications. Patients received individualized education during their visits, allowing providers to consistently reinforce evidence-based recommendations. The goal was to ensure that every patient received consistent, evidence-based diabetes self-management education, regardless of the provider that they saw. The project sample included 68 adults diagnosed with type 2 diabetes who completed both baseline and follow-up hemoglobin A1C measurements in the primary care clinic. Demographic information included age, gender, preferred language, and interpreter utilization. Collecting these variables helped characterize the patient population while ensuring the project reflected the diverse population served within our clinic. All participants met the inclusion criteria and completed both baseline and follow-up hemoglobin A1C measurements. Data were obtained through retrospective review of the electronic health record. Data were analyzed using the IBM SPSS statistics. Descriptive statistics summarize participant characteristics and hemoglobin A1C values. Prior to inferential testing, the Shapiro-Wilk test was performed to evaluate normality, and it evaluated it. Because the data were not normally distributed and a non-parametric statistical approach was then required. Therefore, the Wilcoxon-signed ranks test was selected to compare the paired pre- and post-interventions of hemoglobin A1C values. Here we found that the statistical significance was established at an alpha level of 0.05. Let's take some time to look at this slide as far as the results. This slide presents the primary outcome of the project. The results demonstrated that the intervention successfully improved glycemic control. Before implementation, the mean hemoglobin A1C was 8.17%. Following the implementation of the Educational Standardized Toolkit, the mean hemoglobin A1C decreased to 7.53%. This then represented that a mean reduction of 0.64% in points was accomplished. Although the numerical change appears modest, reductions of this magnitude are clinically meaningful because even small improvements in hemoglobin A1C would reduce the risk of long-term diabetes complications. These findings demonstrate meaningful improvement in glycemic control following that implementation of the standardized diabetes toolkit that was provided to the patients amongst the providers. More in depth, when we look at these key findings, you see that the statistical analysis confirmed that the observed improvement was not due to chance. The Wilcoxon signed ranks test demonstrated a statistically significant reduction in hemoglobin A1C with a z-value of negative 4.85 and a p-value of less than 0.001. These findings indicate that improvement was highly unlikely to occur by chance. These findings support the effectiveness of structured diabetes education for improving glycemic control among adults with type 2 diabetes. Overall, the findings demonstrate that structured diabetes education can significantly improve glycemic control within the primary care setting. These findings are consistent with current evidence supporting diabetes self-management education. Patients appear more engaged in discussions regarding medication adherence, healthy eating, glucose monitoring, and physical activities. At this point, they were given pamphlets with pictures and even written information that was easy to understand, but also using teach-back methods as well. Providers also reported that there was greater consistency when educating patients because everyone utilized the same educational materials. Overall, the intervention successfully addressed the identified practice gap while supporting evidence-based diabetes management. This intervention also supports consistency among healthcare providers delivering the diabetes education. Everything was put together, everyone gave everything the same, therefore just making it a lot easier for providers and for patients, so that even if they saw different providers, they were still getting the same information. There were a couple of limitations, actually several of them, that should be acknowledged. The project was conducted within a single primary care clinic using the primary care convenience sample of 68 participants. The absence of control group limits, the ability to attribute improvements solely to the intervention. There was no comparison group, therefore limiting the ability for us to attribute improvements exclusively to the intervention. Additionally, the follow-up period was relatively short, which limiting the evaluation of the long-term sustainability. And currently, where this was taking place, they have a total of soon to be 4 clinics. And if it was a longer period of time with the higher number of participants, then that would be a little bit more easier, or actually for us to actually see it and streamline it and better evaluate it. This project reinforces the improvement and the importance of leadership role of nurses and advanced practice registered nurses in translating evidence into actual practice. Standardized diabetes education improves patient safety, supports the interdisciplinary collaboration, and promotes consistent delivery of evidence-based care. The project also supports health equity by ensuring that all patients receive the same high quality educational intervention regardless of the provider, regardless of the language and preference, or even the health literacy level. The intervention supports a sustainable practice change and aligns with organizational quality improvement initiatives. DMP has prepared nurses to play the critical role in leadership in translating evidence into clinical practice through projects such as this, which was very helpful and very enlightening, and the change itself and the improvement in A1Cs with this standardized educational toolkit was just amazing. In conclusion, implementation of a structured diabetes educational toolkit improved glycemic control among adults with type 2 diabetes. The project demonstrated that evidence-based patient education can be successfully integrated into routine clinical practice without disrupting the actual workflow. The intervention was practical, it was feasible, and supported current diabetes self-management recommendations. Most importantly, this project demonstrates how evidence-based nursing interventions can improve patient outcomes while strengthening the quality improvement within the primary care. Completing this DMP project has definitely strengthened my leadership skills and reinforced my commitment to translating evidence into practice to improve patient care. It has strengthened my ability to evaluate research, lead organizational change, improve patient outcomes, and collaborate with interdisciplinary teams. This experience has definitely prepared me to continue leading in quality improvement initiatives throughout my nursing career. At this time, I look forward to actually implementing the standardized diabetes toolkit amongst the other 3 locations and amongst the providers, and still just for myself keeping the numbers and being able to track how this standardized toolkit will improve glycemic control. Based on these findings, I recommend continuing implementation of the educational toolkit as a standard of care within the organization. Future quality improvement efforts occur and should occur on focusing the expanding across the primary care clinics, increasing, of course, the sample size, extending follow-up periods so for them to be longer periods of times, evaluating patient satisfaction, and conducting the cost analysis to determine the long-term organizational impact on the standardized diabetes education across the 4 centers. As far as my references that informed me in the development of the implementation of this quality improvement project, here's the list, but the primary supporting are not limited and include American Diabetes Association Standards of Care, the ADCES-7 self-care behavior framework, the Iowa model of evidence-based practice, and the current like peer-reviewed research on diabetes self-management education. I would like to sincerely thank my committee, my faculty, my clinical preceptor, my leadership and staff at Culinary Health Center, Maryville University, my family, and everyone who supported me throughout this journey. Completing this Doctorate of Nursing Practice program has been one of the greatest professional accomplishments of my career, and I am truly grateful for everyone's encouragement and support. I cannot thank you enough. Thank you.